Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. M. Sumugavelu. Sir is MD, FICP, FRCP, FRSSDI, Chairman and Managing Director at Trichy Diabetes Specialty Center, Tamil Nadu. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is pre-diabetes risk, identifying the most dangerous manifestation. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
And thank you, madam, for your nice and generous introduction. Very pleasant evening, and my hearty welcome to all the viewers and listeners of this program. I feel extremely happy, honored, and most privileged to have been invited to make a presentation on pre-diabetes risk, identifying the most dangerous manifestation, with a particular focus on evidence-based findings. I once again thank the entire IGCP team for their kind invitation. Also, thank Madam for her introduction. So, my disclosures, what I'm going to do for another 25 minutes. The contents of a top line includes introduction, diagnostic criteria of pre-diabetes, pathophysiology, prevalence, the natural causes and complications, increased risk of other diseases, and of course, we have many phases of pre-diabetes. Which one I consider scary, I'm going to take all through my presentations. So pre-diabetes is a term used for individuals whose glucose or A1C levels do not meet the criteria for diabetes, yet have abnormal carbohydrate metabolism that results in elevated glucose levels, dysglycemia, intermediate between normoglycemia and diabetes. As pre-diabetes, it is an intermediate stage between normal glucose tolerance and individuals with the diabetes. It is clearly a significant risk factor for progression to diabetes. So individuals with pre-diabetes can progress to diabetes or they can revert back to normal, as well as increased risk for cardiovascular diseases and several other cardiometabolic outcomes. Pre-diabetes is associated with obesity, dyslipidemia with a hypertriglyceridemia, low HDL level, as well as increased circulating levels of small dense LDL and hypertension. It's a heterogeneous entity, and different phenotypes with the different pathogenetic pathways lead to prediabetes. Emerging evidence suggests that prediabetes that is associated with pathological changes in several tissues and organs, which would support its recognition as a distinct pathological entity. So, consequently, the population level health burden of prediabetes is substantial, underlining the necessity for early initiatives to prevent disease development. So, the primary focus should be on identifying the individuals with prediabetes, stratify the risk for future atherosclerotic cardiovascular disease or heart failure or CKD or other diseases, and try to prevent its progression to diabetes. So the prevalence of prediabetes should prompt comprehensive screening for cardiovascular risk factors. Background: the origin and nature of IGT and IFG categories. IGT was first introduced in 1979 to replace borderline diabetes and other categories of hyperglycemia. It was considered as a clinical class of glucose intolerance in 1985 WHO classification. In the latest report from WHO and ADA, categories as a stage in the natural history of disordered carbohydrate metabolism. IFG was introduced in 1991. It was defined in such a way that the prevalence of IGT and IFG were similar in the study cohort of the Paris prospective study. Individuals who meet the criteria for IGT or IFG, they have A1C values that are either within or only just above the normal range. However, even as the degree of hyperglycemia is clearly associated with other metabolic and cardiovascular abnormalities. IGT and IFG are often components of the metabolic syndrome. We know the other components being overweight, obesity, dyslipidemia, hypertension. They carry increased risk for cardiovascular disease and other heart failure as well as CKD risk. The metabolic determinants of fasting, that is fasting plasma glucose, and poor plasma glucose load following oral glucose tolerances, the classical oral glucose tolerance test, they are somewhat different. So the metabolic determinants of fasting as well as 2-hour plasma glucose levels are somewhat different. This means categorization of an individual on a fasting value may differ from that on a 2-hour plasma glucose value. What is prediabetes? Broadly refers to an intermediate state between completely normal glucose levels and the clinical entity of type 2 diabetes, encompassing both IFG and IGT. The definitions of diabetes and prediabetes, they are based on assessment of the disease risk as well as the population of plasma glucose level. Data suggesting there is a threshold of plasma glucose level above which the incidence of retinopathy significantly increases has been used to help define diabetes. So when the plasma glucose level goes or exceeds 126 milligram per deciliter, the incidence of retinopathy significantly increases. And it has been used to help define diabetes. Diagnostic criteria of prediabetes. Fasting glucose alone, that is reported to miss the detection of approximately 30% of cases of type 2 diabetes. So if we focus only on fasting plasma glucose level, the chances we might miss. In the Ranko Bernardo cohort, nearly 70% of women and 48% of men aged between 50 and 89 had new diabetes diagnosed on the basis of elevated 2-hour plasma glucose alone. Always bear in mind oral glucose tolerances and its importance. In the diabetes prevention program, 87 cases of new diabetes were detected based on initial elevation of 2-hour plasma glucose level as opposed to only 35% that were detected based on initial elevation of APG. Upon presentation, OGTT should be considered to definitely diagnose whether the patient has prediabetes or has unrecognized type 2 diabetes. So fasting and administer 75 grams of glucose load and check 2 hours after the administration of 75 grams glucose. That is to confirm prediabetes as well as unrecognized type 2 diabetes. So the diagnosis impacts prognosis because patient diagnosed with IFG and IGT, they develop diabetes approximately twice as often as individuals with either isolated IFG or isolated IGT. So subjects with IFG and IGT, combined IFG IGT, they develop diabetes more frequently compared to patients presenting with isolated IFG or isolated IGT. In addition, cardiovascular risk is greater in those with IGT or diabetes based on 2-hour plasma glucose level. There is growing acceptance for the role of A1C in the screening, diagnosis, and prognosis. So all parameters should be assessed initially, confirming the patient diagnosis of prediabetes and excluding the possibility of undiagnosed diabetes. So pre-diabetes diagnostic criteria, RSSDI, and other recommendations. So normal glucose tolerance. So fasting below 100 and 2-hour plasma glucose level, that is more less than 140. And patient with IFG, impaired fasting glucose, 100 to 125, and non-diabetes less than 200 milligram. Isolated IFG between 100 to 125. Please bear in mind, isolated IFG means 100 to 125. Non-diabetes, that is here 200 and here less than 140. So impaired glucose tolerance. Non-diabetes, that is fasting plasma glucose, less than 126 and falling 75 grams glucose ranges between 140 and 199. Isolated IGT, fasting less than 100 and 140 to 199. Combined IFG and IGT, 100 to 125 fasting and falling 2-hour plasma glucose 140 to 199. That is combined IFG and IGT. So RSSDI 2022 clinical practice recommendation diagnosis criteria for diagnosis of prediabetes and intermediate hyperglycemia. Impaired fasting glucose, impaired glucose tolerance, and A1C between 5.7 to 6.4. The decision to set diagnostic threshold values, it was based on the cost-effective strategies for diagnosing diabetes that was reviewed in the Indian context. That is based on the 2022 clinical practice recommendations. Next is WHO, ADA, and Canadian Diabetes Association criteria, at least one of the conditions. So fasting plasma glucose level 110 to 125, here 100 to 125 and 110 to 125. 2-hour oral glucose tolerance test, That is 140 to 200, 140 to 200, and 140 to 200. Based on HbA1c, that is A1c value, 5.7 to 6.5 and 6 to 6.5%. So complications, especially cardiovascular disease, have been observed at the ADA fasting plasma glucose cutoff of 5.6 millimole and A1C cutoff of 5.7. So they have taken into consideration fasting less than 100 as normal. It may be cost effective to rely on the ADA criteria with regard to when to recommend therapeutic lifestyle measures, pharmacological treatment, or even bariatric surgery. So the ADA also introduced the use of A1C levels between 5.7 to 6.4 as a new category of high diabetes risk. So A1C less than 5.6 normal, 5.7 to 6.4 pre-diabetes, and greater than 6.5 as diabetes. So in a community-based study of African American and non-Hispanic white adults with diabetes, baseline A1C was a stronger predictor of subsequent diabetes and cardiovascular events than fasting plasma glucose level. So A1C range of 5.7 to 6.4 identifies a group of individuals at high risk for diabetes and cardiovascular outcomes. Please always bear in mind and keep it in your mind. So similar to those with IFG and IGT, individuals with A1C of 5.7 to 6.4, they should be informed of their increased risk of diabetes and cardiovascular disease and counseled about effective strategies to lower the risk. Our aim is to prevent the patient from developing diabetes, at the same time stratify the risk and prevent the patient from developing cardiovascular disease, heart failure risk, as well as CKD. So aggressive interventions and vigilant follow-up should be pursued for those considered at very high risk. Those with A1C greater than 6 and individuals with both IFG and IGT. So patient presenting with combined IFG and IGT or A1C greater than 7%, they need aggressive intervention and vigilant follow-up. So pathophysiology pre-diabetes. So both isolated IFG and isolated IGT, they are characterized by insulin resistance and impairment of insulin secretion. So combination of these two. Individuals with isolated IFG, they manifest hepatic insulin resistance, so fasting hyperglycemia. Normal skeletal muscle insulin sensitivity, so post glucose load glucose levels are within normal range. Those with isolated IGT, they are characterized by more severe muscle insulin resistance and less severe hepatic insulin resistance. So fasting more or less near normal. On the other hand, post glucose load, glucose values are very high. So differences in insulin secretory abnormalities. They are also apparent between subjects with isolated IFG and isolated IGT. So isolated IFG, they have defects in first phase insulin secretion in proportion to their fasting hyperglycemia. Isolated IGT, they have more defects in second phase insulin secretion. And those with IFG, they tend to have elevated endogenous glucose production due to hepatic insulin resistance, the reduced hepatic glucose clearance, and impaired beta cell function. Next is individuals with IGT, primarily characterized by resistance in the skeletal muscles, leading to delayed glucose uptake along with the beta cell dysfunction. So individuals with the combined IFG, IGT, they manifest both hepatic and muscle insulin resistance, impairment in both first and second phase insulin secretion, so closely resemble subjects with the type 2 diabetes. So the risk of developing cardiovascular disease, the risk of developing heart failure, CKD risk, as well as progression to type 2 diabetes are very high and greater. So various biomarkers may also be of value to better define which subjects will develop. So inflammatory markers, CRP and PI1, that is plasminogen activated inhibitor 1, they were associated with the diabetes development in individuals with pre-diabetes. Beta cell mass decrease up to 40% in pre-diabetes and 60% in diabetes. That accounts for impaired beta cell function, beta and insulin secretory defect. Autopsy studies shows both pre-diabetes and diabetes are associated with the reduction in the beta cell mass. It is the functional reduction in the beta cell mass that results in fasting as well as post-meal hyperglycemia. We have the genetic markers like TCF7, that is transcription factor 7L2, which plays an important role in growth and development of the beta cell, as well as increased generation of incretins. And individuals exhibiting this particular transcription factor abnormalities, they may present with diabetes as well as increased risk for chronic kidney disease. So the South Indian phenotype. We get the Indian phenotypic, thin fat Indian or sarcopenic obesity, young age at onset, hyperinsulinemia, followed by rapid decline in beta cell function and severe insulinopenia, lower body mass index but excess ectopic fat. Even though the body mass index is within normal or less than normal, there is excessive deposition of fat in the ectopic side, namely the liver in the abdominal viscera, and lower birth weight, thin fat Indian, low muscle mass, characteristic dyslipidemia, reduced levels of adiponectin, increased circulating levels of inflammatory markers, increased tendency for non-alcoholic fatty liver disease, the metabolic dysfunction associated fatty liver disease, low vitamin B12 and low vitamin D, and gut microbiota dysbiosis. So Asian Indian phenotype with increased high insulin resistance has been shown to has in progression to type 2 diabetes. But defects in beta cell function and insulin secretion that is greater than insulin resistance in Asians with prediabetes, predisposing them to rapid progression to development of type 2, even patients present with the mild insulin resistance. In other words, beta cell dysfunction appears to be the main predominant defect in both IFG and IGT, and combination of higher insulin resistance and greater beta cell dysfunction that is responsible for the rapid conversion. So prevalence. So ICMR in-depth study, cross-sectional population-based study, assess the representative sample of individuals aged 20 years and older. And if you look into the projections for metabolic disease prevalence, that is patient with the diabetes, pre-diabetes, dyslipidemia, hypertension, as well as generalized obesity, the overall weighted prevalence was 11.4%, pre-diabetes 15.3, hypertension 35.5, obesity, abdominal obesity, dyslipidemia. So the prevalence of diabetes and other metabolic NCDs in India that is considerably higher than previously estimated. So in 2021, around 720 million individuals were impacted by prediabetes, and the same projected will rise to about 1 billion people by the year 2045. According to ICMR in-depth study, India had 101 million cases of diabetes and 136 million individuals with prediabetes in 2021. So the nationwide prevalence of prediabetes, which included urban and rural areas of nearly all states, was reported as 15.3. So huge burden of prediabetes points to worsening of type 2 diabetes burden in our country. The conversion rate of prediabetes among Indians is also very high. So the high prevalence of prediabetes, even in rural areas of several states, that is alarming as it points to the spread of the disease epidemic to rural India. So type 2 can be prevented with effective interventions in the pre-diabetic state. So risk of progression to type 2 diabetes in various pre-diabetic groups, the pre-diabetic population versus the normoglycemic population, ADA, plasma glucose criteria. The meta-analysis showed that the incidence of type 2 diabetes was higher in patients with isolated IFG, isolated IGT, and ADA, IGT plus IFG groups than in the ADA, normal fasting glucose and normal glucose tolerance. So subjects with combined IFG and IGT, next subject with isolated IGT and subject with isolated IFG, they carry increased risk. Natural causes and complications. So patient presenting with prediabetes, they have endothelial vasodilator dysfunction, which precedes the onset of IFG, IGT, and type 2. It occurs early in the pathogenesis of atherosclerosis. There is endothelial fibrinolytic dysfunction, which contributes to increased risk of cardiovascular disease in individuals with insulin-resistant prediabetes and diabetes. So insulin-resistant, that precedes prediabetes, and type 2 diabetes contributes to endothelial dysfunction. In fact, if you look into the natural history of prediabetes, the insulin resistance develops several years before the onset. Patient develops fasting or post-meal hyperglycemia. Vascular insulin resistance that leads to reduced vasodilator response in patients with prediabetes or diabetes. So these factors give rise to oxidative stress, inflammation, and endothelial vasodilator and fibrinolytic dysfunction in prediabetes and diabetes alike. Next is adipose tissue that also influences systemic endothelial function through secretion of inflammatory cytokines. So these inflammatory cytokines released from the adipocytes also interferes with insulin secretion as well as insulin action. So the pro-inflammatory pre-diabetic and diabetic state results in increases in the skeletal muscle collagen, other, other extracellular matrix proteins, and extracellular matrix remodeling. This can cause endothelial dysfunction, capillary regression, and increase extracellular matrix component interaction with cell surface receptors. And microRNA may promote endothelial dysfunction by inhibiting the genes involved in angiogenesis, vascular repair, and inflammatory suppression. So, what is the natural cause of untreated prediabetes? Progression from pre-diabetes to type 2 occurs for many years, and the risk of progressing to diabetes is greater in individuals with combined IFG IGT compared with isolated IFG or IGT alone, and it depends on the degree of insulin resistance, deficiency of insulin secretion, as well as other diabetes risk factors such as age, family history, overweight, obesity, or previous history of GDM or polycystic ovarian disease. So the average annual risk of developing diabetes for someone with normal glycemia is approximately 0.7 per year. The risk is about 5 to 10 per year in individuals with IFG or IGT. In the diabetes prevention program, which enrolls subjects with elevated fasting plasma glucose and IGT, 11% of individuals in the standard arm progress to diabetes. Over the time, majority of patients with IFG, IGT, or both would develop type 2 diabetes in the absence of intervention. So pre-diabetes is not only a significant risk factor for progression to type 2, but is also considered risk factor for microvascular disease and also for retinopathy. And a meta-analysis of 38 prospective studies suggests that post-challenge blood glucose levels in the non-diabetic range appears to have a linear relation with cardiovascular disease and a possible threshold risk with FPG of about 100 milligrams. So pre-diabetes and increased risk of other diseases. So increased risk of cardiovascular disease. So pre-diabetes increases risk of CVD by 20% compared with healthy individuals. And there is reported evidence of increased CVD risk as early in the stage of normal glucose level, just below the pre-diabetes threshold. Right. Many studies consider IGT a strong predictive factor for CVD mortality, morbidity, and increased risk of CAD and higher prevalence of pre-diabetes in patients with CAD. And not only that, there is increased risk of CAD in participants with IFG. And numerous studies have shown a poor prognosis, that is higher recurrence and overall mortality when compared with individuals without glucose metabolism. Right. Recent meta-analysis conducted in 2021, which involved 15 studies, found a significant association between pre-diabetes and the occurrence of incident heart failure in comparison to normal individuals with the normal glycemia. So CVD risk, morbid mortality, CAD risk, and prognosis associated with pre-diabetes in patients with the CAD and heart failure risk all are increased. Increased risk of stroke. So after adjustment, there is an independent association between IGT combination of IFG and IGT and increased risk of future stroke. In addition to the risk, pre-diabetes is known to be linked to poor prognosis, very important, as in the case of CAD. Next is cognitive dysfunction. Increased occurrence of cognitive impairment has also been reported. Next is increased risk of peripheral arterial disease. So higher prevalence of PAD in comparison with individuals with normal glucose metabolism. Next is increased risk of retinopathy. Based on findings from the diabetes prevention program, 8% of the pre-diabetes have clinical signs of retinopathy. So always bear in mind. And Cheng et al. Reported A1C to discriminate prevalence of retinopathy better than FPG and increase the risk of nephropathy. So evidence is more convincing for the impact of pre-diabetes on the development of nephropathy. So many studies suggested that non-diabetic range of hyperglycemia that is associated with increased risk of albuminuria, which is considered the earliest marker of diabetic nephropathy. Next is neuropathy. Again, there is evidence that prevalence of peripheral neuropathy has an increasing gradient from normal glycemic persons to those with IFG and IGT2 diabetes. And next is increased risk of cancer. Pre-diabetes is also associated with increased risk of cancer. Approximately 15% more likely to develop cancer. And pre-diabetes and cancer have many common aspects that are linked both epidemiologically and biologically. So what is the evidence supporting intervention for pre-diabetes, and does treatment alter the natural course of pre-diabetes? So lifestyle approaches, metformin therapy, lifestyle changes have consistently demonstrated benefit in preventing or delaying the progression. And this particular Chinese study involving several hundreds of patients with IGT, one of the first to show the benefit of long-term diet and exercise intervention to prevent diabetes. So lifestyle modification remains the cornerstone, and it can prevent progression from pre-diabetes to type 2 diabetes. And Finnish diabetes prevention study and US diabetes prevention program demonstrated a 58% reduction in the progression from IGT to diabetes with intensive lifestyle. in diabetes prevention program, lifestyle intervention with a goal of at least 7% weight loss and 150 minutes of physical activity appear to have greater impact on older persons and those with a lower BMI. And follow-up of Finnish diabetes prevention study, participants were followed for an additional 3 years after the 4 year intervention period. No diet or exercise counseling provided in the follow-up visits. During the total follow-up, the intervention group maintained 43% reduction in the relative risk of developing diabetes. That clearly shows the impact of early intervention. Lifestyle measures and lifestyle approaches continue to maintain their legacy. So these are the key features of selected published recommendation on pre-diabetes, the definition and ADA consensus statement, Indian Health Services, as well as Australian Diabetes Society guidelines. So should this patient pre-diabetes be treated again? Stratifying those with pre-diabetes and without, based on short and long lifetime estimated risk of diabetes, diabetes-related complication and comorbidities. So screening, identify, diagnose pre-diabetes, stratify the risk, whether the patients are overweight or obesity or obese, whether they have dyslipidemia, hypertension, and calculate the lifetime risk score for atherosclerotic cardiovascular disease. They carry increased risk for heart failure and CKD. With other risk factors such as hypertension and hyperlipidemia, individuals with a high risk of diabetes and related complications will need lifelong support, including focus on controlling body weight. And of course, the evidence is undisputable that diabetes can be delayed or prevented by either intensive lifestyle modification or variety of pharmacotherapies. And lifestyle intervention is a highly cost-effective method of treating prediabetes. So ADA consensus statement stratifies the therapy based on IFG, IGT or combined IFG, IGT and lifestyle modification with a weight goal loss of 5 to 10% along with moderate physical activity of about 30 minutes. And according to the metformin is considered in individuals less than 60 years, BMI of at least 35 kg, family history of diabetes and dyslipidemia, reduced HDL, elevated triglycerides, hypertension, and A1C more than 6%. These are all the consensus statement endorsed by ADA. So it is important to review with the patient that there are limited data demonstrating long-term health benefits of pharmacological intervention compared with the lifestyle intervention. So ideal pharmacological intervention must demonstrate long-term safety, health benefit in terms of reduced incidence of diabetes, macrovascular complications, mortality benefit, cost effectiveness, and it should slow down the progression from pre-diabetes to diabetes. These are all the summary of recommendations on the use of metformin. ADA, European Society of Cardiology and EASD guidelines, as well as NICE UK guidelines, and pre-diabetes algorithm that is endorsed by American Association of Clinical Endocrinologists. See, assess whether the patient has overweight or not, and the goal to treat dysglycemia. They have given on the top of standard of care lifestyle intervention, metformin, pioglitazone, or acarbose. Next is RSSDI, pre-diabetes, that is Research Society for Study of Diabetes in India, clinical practice recommendations, intervention with appropriate lifestyle modification, linking screening strategies, and people with pre-diabetes should modify the lifestyle, including 5 to 10% of the body weight loss, participate in physical activity for at least 1 hour for obese, and 30 minutes for normal weight, and 6 to 8 hours of sleep. So sleep, diet, as well as activity. And patient with pre-diabetes failing to achieve any benefit on lifestyle modification, metformin, younger individuals with one or more additional risk factors for diabetes, if overweight, obese, having IFG, IGT, or IFG with A1C more than 5.7, the addition of metformin is recommended. Alternatively, if metformin is not tolerated, alpha glucosidase inhibitors such as acarbose or oglibose. So patient with the pre-diabetes should be educated on weight management, stress management, avoidance of alcohol and tobacco. When should one escalate intervention for pre-diabetes? Is the primary goal complete normalization of glucose level? How will the primary goal reduce long-term morbidity and mortality? We look forward goals in type 2 to address these important complications. Given this finding, reasonable goals in pre-diabetes include prevention of glycemic deterioration as an indicator of preservation of beta cell function and modification of non-glycemic risk factors like overweight, obesity, dyslipidemia, hypertension, cessation of smoking, and alcohol. Dyslipidemia and hypertension to minimize long-term cardiovascular risk. So, South Indian phenotype, and we have the lessons learned. Phenotype present from birth and continues through childhood and adolescence And we have the ethnic, genetic, and introducing factors, lifestyle-related factors, and exposure to air pollution. And the solutions are improving the nutrition in mother during, that is before pregnancy as well as during pregnancy. From childhood, modify the lifestyle with reference to carbohydrate intake, protein, fiber, and promote improvement in physical activity. Right. So many phases of pre-diabetes. Which one is most scary? That is, pre-diabetes is a major but silent incubator of future morbidity. The prevalence of pre-diabetes is high, and patients with pre-diabetes, they are at increased risk of developing diabetes, diabetic complications, other related disease when compared with those with normal glycemia. FPG provides incomplete picture of chronic glycemic control and change, providing poor sensitivity. Next is postprandial hyperglycemia due to insulin resistant, insufficient beta cell compensation. They are more often present in pre-diabetes than fasting hyperglycemia. At lower levels of A1C, postprandial glucose contributes more to overall diurnal hyperglycemia. Progression from pre-diabetes to type 2 occurs over many years, depending on the degree of insulin resistance or beta cell dysfunction, as well as other diabetes risk factors. And diabetes has been identified as an independent risk factor for CVD mortality, and other risk factors include obesity, hypertension, dyslipidemia, frequently coexist in patients with the diabetes, and multiple studies have demonstrated CV events increase linearly with 2 or post-challenge plasma glucose levels well below the levels diagnostic of diabetes. And recent data with the diabetes prevention program, 7.9% of patients with IGT had findings consistent with retinopathy, and 12.6% of the patients with the diabetes had evidence of retinopathy early in the conversion to pre-diabetes. Evidence is accumulating that macrovascular disease is associated with a lesser degree of hyperglycemia than is microvascular disease. So if you look into the levels of the plasma glucose level as well as the A1C, they are very low. That is, these levels are very lower. Risk of CVD events, that is, extends to the IGT category. And as with diabetes, IGT is often associated with metabolic syndrome. Data suggests that relationship with the 2 over glucose is at least partially independent of either CVD risk factors, but that this is the only case for fasting glucose more than 7. It is worth emphasizing that irrespective of the extent to which the association between fasting and 2 plasma glucose with mortality or statistically dependent on association with other cardiovascular risk factor, hyperglycemia by either measurement is a marker for premature death. Non-diabetic hyperglycemia is just one of several risk factors that CVD and type 2 share. This sharing of risk factor has been described as common soil. So individuals at risk of developing diabetes is also at risk of CVD, and effective measures to prevent both conditions have much in common both at the individual. So the population level health burden of pre-diabetes is substantial, underlining the necessity for early initiatives. So numerous studies have shed light on the multifaceted nature of pre-diabetes. Among these manifestations, dysglycemia stands out as particularly scary and concerning due to its direct potential for serious health implications associated with the metabolic disorders and diagnostic challenges. So, the significance of dysglycemia cannot be overstated as it carries severe health outcomes, often without exhibiting clear symptoms, making it a critical area of attention. So, it is imperative to prioritize the early detection and understanding of dysglycemia to prevent the onset of more severe metabolic risk and promote health and well-being. So collaboration with healthcare professionals, community initiatives, and support networks can empower high-risk population to bring sustainable changes. So before I conclude, I request our learned audience to keep the dates blocked. We at RSSDI national level going to conduct the fourth RSSDI Research Retreat 2025 in Madurai on 1st and 2nd March. Thank you very much for your kind listening. I once again thank IGCP for the kind invitation. And of course, I'll stop sharing my screen. I'll take up the questions in the chat box.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Yes, madam, proceed.
Yeah. So, sir, the first question was, what are the common manifestation of pre-diabetes and which one pose the greatest risk for progression of type 2 diabetes?
Of course, if you think type 2 diabetes, majority of the patients they remain asymptomatic. Only 30 to 40% of the patient they present with symptoms, and most of them type 2 diabetes is often diagnosed during an acute medical emergency or when they go for insurance policy. Similarly, pre-diabetes patients, you never get any symptoms because the plasma glucose levels are below the diabetic range. So most often they may not present with diabetes. But if you come across any patients with a strong family history of diabetes, and if the patient is obese or overweight, when they present with the dyslipidemia or hypertension, kindly screen the patients for pre-diabetes, for which fasting plasma glucose is mandatory, as well as 2 hour following 75 grams of glucose. Both are very much needed to stratify the risk because individuals with the combined IFG and IGT, they carry increased risk for not only type 2 diabetes progression but also cardiovascular, atherosclerotic cardiovascular disease. So early screening and identification is very important. They may not present with any symptoms.
Thank you so much, sir. There is another question. What role does early intervention play in mitigating the progression of high risk pre-diabetic symptoms to more severe complications?
Yes, of course. I told you I have shown many slides, starting from increased incidence of cardiovascular disease, morbid mortality. Next is increased risk not only with reference to CAT, the prognosis is also bad with reference to recurrence. Next is heart failure incidence is very high, including CKD risk. Right. If you consider those patients, kindly look into the socio-economic burden to the individual, to the society, as well as to all the family members. So here is a disease, pre-diabetes, which can progress on to type 2 diabetes. You need not wait till the patient develops patient develops type 2 diabetes before they develop any microvascular as well as macrovascular complications. Patient presenting the pre-diabetes, they carry increased risk for retinopathy. They carry increased risk for increased urinary urinary albumin excretion. They present with overweight, obesity. They present with the dyslipidemia or characters or hypertension. All these are risk factors making the individuals with pre-diabetes to develop cardiovascular disease much earlier before they develop sufficient threshold to develop diabetes. So patient with pre-diabetes, one of the components of the metabolic syndrome, they develop atherosclerotic cardiovascular disease. They need not pass on to the stage of diabetes to carry increased additional risk for them to develop atherosclerotic cardiovascular disease or heart failure or CKD.
Thank you, sir. There is one last question. How do cardiovascular and metabolic condition interact with prediabetes to amplify the risk of severe health outcomes?
Yes, of course. That also I have shown one of the slide. Because patient present with pre-diabetes, if you look at the primary pathogenic abnormalities that give rise to, one is insulin resistance, and there is impaired beta cell function. That is insufficient insulin secretion. Insulin resistance precedes several years before the onset of glucose abnormality. It is at this stage of that is insulin resistance. The beta cells can contract the insulin resistance by increasing its function, increasing the insulin secretion to contract. So early stage normal glucose tolerance is maintained. However, the beta cell are no longer able to contract the insulin resistance. So it is the insulin resistance that results in inflammation, that results in oxidative stress. It is associated with hyperglycemia. It is associated with abnormal lipid levels. So, glucotoxicity, lipotoxicity, inflammation, oxidative stress. The earliest pathogenic abnormality we come across is endothelial dysfunction. There is a change with reference to alteration in the fibrinolytic system. So, collectively, this will result in the vascular insult and abnormalities with reference to coagulation profile, fibrinolytic system abnormality, and resulting in increased tendency for them to develop atherosclerotic cardiovascular events.
Thank you so much, sir. That's all from our audience. Thank you for answering all our questions, sir. Before concluding, any take home message from your end?
So I request all of our viewers and listeners, please screen the patient, identify the patient with glucose abnormality, talk to them and give a positive motivation as well as positive education, and inform them about the need for weight reduction if they are overweight or obese. Also, inform them about the management of dyslipidemia and hypertension. So, in the long run, patient can have a good quality of life.
Thank you so much, sir, for joining us today. And with your permission, sir, I would like to conclude today's session. Thank you.
Thank you very much for your kind invitation. Also, thank all the participants for the kind listening.
Thank you, sir.